Good morning.
Good morning.
Good morning.
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 All right. Any questions before we get started this morning? All right. Well, hearing none, I am going to talk just a little bit about your next test before we get started. So your test will consist of 50 questions, and you will have approximately 20 from today's lecture and 20 from last week's lecture, and then 10 from the sensory content. So that's how you can kind of plan your study time based on your weight of the test. And so the main thing that I'm looking for on the test is that you understand what your nursing care is and how to manage a patient. My questions are very nurse oriented. And so you'll be wanting to make sure that as you're studying that you're focusing on what you would need to know as a nurse to take care of a certain kind of patient. It's to me to study this material in such a way that you are not necessarily studying by yourself. I know a lot of people kind of stick to themselves and really don't want to study with someone else, but it's often helpful to study in a small group. I recommend that if you decide to do that, that you make a pact with your group that it truly is to study and not to socialize or talk about anything else. And then, you can help each other by keeping everything on track. And you might want to study for like an hour and then take a 15-minute break to get snacks, go to the bathroom, talk to each other for a little bit, and then jump right back into it. But it's going to be really important for you to just keep it focused. However, the best way to do that when you're in a small group is for each person to take a topic. So like maybe one of you would take electrolyte imbalances. And so you kind of go around and each person would ask the others a question from that content area. And this is to make sure that you understand and can apply what you've studied, because this first test is a little bit hard for you guys because you're not used to answering questions about pathophysiology and more nursing actions. And so the first one is kind of a getting used to it test, but the best way that you can prepare for that is to ask each other questions. So you might, ask somebody, all right, when you see a patient with hyperkalemia, what would you expect to see in the patient? And so you would be looking for those symptoms that set apart potassium elevations from everything else. And then, you could say, well, why would we give somebody KXLate? Or why would we put them on a heart monitor? those kind of things. So you want to ask each other questions that demonstrate the ability to apply the information. What you don't want to do is just ask questions that rely on rote memory from the notes or the PowerPoints or lectures or whatever, because very few of your questions are going to focus on just rote memorization of material. Your questions from here on out till you graduate are going to be more focusing on how do I care for a patient with blah, 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 or how would I know that this patient has this disease, or what would I need to teach them to provide self-care or to prevent a recurrence of X condition. So those are the kind of things that you want to be thinking about. And if you can do patient teaching on something, then you probably know it pretty well. So, if your topic is diabetes, then you might want to ask your peers, well, tell me about the sick day rules, or tell me what's the correct way for them to take care of their feet. And how would you know that somebody had been compliant and that their medication regime for diabetes was appropriate? So those are the kind of things that we're going to be looking for. Now, that being said, do you have any questions about the first test?
I don't have any at the moment.
I'm sorry?
I was just saying I don't have any at the moment.
Oh, okay. All right.
I have one question.
Okay.
So you're saying that the questions are going to be geared around what to do for the care of the patient. What is the clinical manifestations, like the signs and symptoms, and how we need to teach the patient?
Yes.
Okay, thank you.
Now, there may be a few questions that ask you about what is the presenting symptom of this disease, which is kind of knowledge-based. But the largest majority of them are going to be application. Now, if you'll put this on your calendar on February the 8th, which is a Tuesday, from 5 p.m. to 7 p.m., I will have a review session for test 1.
Is that at the campus or is that a Zoom?
It'll be Zoom.
Thank you.
It'll be Zoom. Now, what that means is that I'm not going to just sit there and say, well, you need to know this or you need to know that. This is truly a time for you to bring your questions forward, and I will have a tutoring session before each test. And it might not always be on Tuesday. It will probably be on Tuesday most weeks. I try not to do it on Thursday because I feel like you need to have it a few days before the test. But in a pinch, I'd rather do it on Thursday than not at all. But I will try as much as possible to keep those on Tuesdays. So that will give you a chance to log into the Zoom and to ask questions. So I would challenge you that as you study, if you would write down questions that you have or things that maybe you wanted to mention or ask for clarification on, then that will help you make these pre-test study sessions a little bit more focused and a little bit more beneficial to answer questions. And you can probably assume that if you have a question, somebody else has it too. So If you just will bring it forward and let me go over it and clarify whatever needs to be clarified. But if you guys don't bring any questions, then it winds up being kind of a useless session, because I can sit up there and talk about something, but whether that's what you need to know or not is a whole different thing. If it's something that you know well or that was easy to understand and there are no questions, for me just to go over it again is pretty pointless. And so it will be much, much better if you're able to bring your questions. All right, so anything else?
Are the questions going to be short answer or like different kinds of questions?
Your questions will be multiple choice. Select all that apply. You may have some chart entries to read and make a determination. You may have some pictures that you would need to look at and respond to. But even when there are pictures and graphics and those kind of things, basically your questions are either multiple choice or select that apply. In Nursing 155, there will not be any essay questions. There will not be any matching or true false. So it's pretty much multiple choice and select all that apply.
Okay, thank you.
And while we're on the topic of test questions, let me just tell you a little bit about these select all that applies. As you move through the program, the number of select all that apply questions that you get is going to increase. And that is just sheerly to get you ready for the NCLEX. And students always flip out when they see these select all that apply questions. And that heightens your anxiety. But the way that you want to approach these select all that apply questions is to treat them as if they were true false statements. So, when you were a kid and you were taking a test in school, you had a test that maybe had a couple of multiple choice and maybe some true false and some matching, and then maybe a discussion or two, but your test had a lot of different things on it. Well, think about your select all that apply questions as being that section of true false. So if you break the question down into individual true false statements, it's much easier for you to deal with. So what that means is you would look at each individual part and say, okay, in this situation, is this true or is this false? And then you only have to decide, okay, do I need to pick the true answers or do I need to pick the false answers? But if you break it up like that, it actually makes it much more manageable and easier for you to think it through. So get into the practice when you have those select all that applies of turning it into just one section of true false. Okay.
How long is the test?
Generally speaking, a 50-item test is 60 minutes. For this test and the next test, we may allow you just a little bit more time because of the content. The content is a little bit harder, I think, just because you're not used to fluid and electrolyte balance and the perfusion stuff. That stuff's pretty heavy stuff. And so we would probably allow you 70 to 75 minutes. The way we come to that is that on the NCLEX, you're given 1.3 minutes per question. Now, that doesn't mean that after 1.3 minutes, you have to move on. What that means is if question number 1, you answer it in 30 seconds, and then on question number 2, you have to sit and think about it, and it takes you 2 minutes, your time overall that is allowed is 1.3 minutes per question. And so that's why your tests are timed the way that they are. So you want to make sure that you're kind of moving along. By, if you're in the 8:30 class, by 9 o'clock, you should be about number 26. If you're not, then you need to look at what number you're on and decide if you're going too fast or too slow. You can take a test too fast, and just make some really bad choices from not thinking it through. Whereas if you get to, 9 o'clock and you're on number 20, then you know that you're kind of off pace a little bit and you may have to pick it up. You will not be able to move back and forth through the test. You'll have to answer each question and then move on. And then we will normally post the grades that day or the next, depending on how the faculty are able to get together and grade it. And when I say grade it, what that means is that we sit down and look at the statistics for every single question. For any question that half or more of the class missed, we'll look at all the distractors and we'll look and see what answers were being chosen, and we'll determine if there should be any adjustments in the test or not. Now, this next part is important. If you have a question regarding a test question, you need to email the lecturer and ask the lecturer about it. But if you're going to say, I was answering this question and I felt strongly that this was the answer, then you need to have something to back it up. Not just, well, I thought this was the right answer. So you'd want to give something from the lecture or the book. Now, if you go to Google and find something and say, well, Google said this, we're not going to entertain that because that was not in our materials. So stick to our materials. And, be sure that you're emailing the lecturer your questions shortly after the test. You don't want to wait. And with 2 weeks after the test, we won't make any further adjustments. So we have that 2-week period that we can entertain any questions, but you're really better off to ask them, as soon as you can, because you're going to remember more, and that will allow us to get any corrections made before the grades are posted.
Ms. Amos, will we know which questions we missed?
Yes, because you will. That's a good question. It's a great point. We will not review tests after the test. What I mean by that is your tests will be set to allow you to review what you missed immediately once the test is over. And so it's your responsibility to review those things that you missed so that you know what they were. And so it's important for you to stay in your seat after you finish your test, after you submit it, and read the rationales for those things that you missed, because we will not have a separate review. Okay?
Will we be able to see the correct answer when we review them?
Yes, you will. but you will only be able to see those questions that you missed. You won't see, if you got the question right, it will not show you the question, but you will be able to see the question and the correct answer for every question that you missed. So that's why we ask you to be sure that you review those questions that you missed before you get up from your seat. Some people say, well, I forgot, or I didn't feel like sitting there, or whatever. But that is your time to review. And so that's part of the expectation of your testing, that you review right there in class. Okay. If something happens during your test, let's say that on number 38, you knew that B was the right answer, but somehow or another you hit A and you realized it after you hit submit. At that point, then we expect you to raise your hand and let the proctor, whether it's in the testing center or whether it's in the live class, we would expect for you to raise your hand at that point in time and say, I just realized I put the wrong answer, and I move forward. Once you submit your test and the correct answers pop up, we can't do anything for you. So you want to make sure that you're doing it during the test. And if you are doing it, if you are raising your hand during the test and saying, I made a mistake, we will write it down and we will adjust your grade accordingly. But you have to do it before you submit your test. Okay.
Would you be able to share like the statistics of from past classes about the grade average for this test?
I could, but if it's a different test, I don't know that that would be very beneficial. I will tell you that the first test is usually the one that people score lower on, just because they're not used to taking these kinds of tests. But that's one of the reasons why we started the class prep activities and why we're using the SurePath questions, because that helps to prepare you for the kinds of questions that you're going to see on these tests. Traditionally, the class average is anywhere probably from 78 to 84, depending on the test and the semester. Now, what does a class average mean?
Grades of all the students, and then divided by the number of students.
Okay. Well, if the class average is 85, that means most of the class were around 85, but then you had some outliers that might have had a grade of 92, but then you might have had some grades of 72. So an average is what most people were closest to, but then you have to remember there are some higher and there are some lower. So I don't want you to think, oh gosh, if everybody made 70, 78 to 84, well, that's not my expectation of what grade I'll make. Well, no, it's not. But for every person that makes, a high grade, there's usually an equal number of people or close to it that don't make such a high grade. And so the average is kind of relative to how you as an individual score if you prep for the test and are aware of how to prepare. And that's why I wanted to talk just a little bit about studying in a group and making your time worthwhile by quizzing each other in such a way that you're asking each other to apply the information, not just spit the information back out. So flashcards are great, and I have no problem recommending flashcards, but flashcards often are used for knowledge-based stuff. And oftentimes, Ms. Coates, Ms. Petrarca, and I will meet with a student who's not doing very well, and they're like, ask me something. I know I read the book, I know every word of the notes, I know the material, but I can't pass the test. And that can be a very true statement, because it is not like a gen ed class where you can study the material and spit it back out on a test. This is very different because you have to apply what you learned. So if you're using flashcards, that's great to learn the material, but don't stop there. Make sure that you, more than just knowing the material, you know how to use it. People say knowledge is power, and to a certain degree, I would support that, but knowledge, the more you can apply that knowledge to something else, the more powerful it becomes. And so you want to make sure, excuse me, that you can apply it as necessary. Make
Just
sense?
a quick question. I just want to, I'm trying to make it make sense to me. So as far as with the acid balance, right? You gave us
Yes.
some lab values. So yes, we need to know what the lab values are. So when we get a scenario and something is
Correct.
low or high, we have to apply the care for those abnormalities, correct? That's what you mean by application?
Yes. So if I give you an ABG result on your test, I might just ask you, well, what does this ABG represent? And it would be either metabolic alkalosis or acidosis, or respiratory alkalosis or acidosis. But then I might say, based on these ABG results, which of the following interventions is a priority? So in that question, you have to determine what's wrong with the ABG, and then you have to know what to do about it. And so that's the kind of, most application questions require two steps. They require that you assimilate the information together to come up with what's going on. And then the question is going to ask you to take that information and then figure out what you need to do about it. So when we say application questions, that's what we're talking about. We're truly talking about you being able to take a scenario, read it, determine what's going on, and then decide as a nurse what action you should take. So is that helpful?
Yes, thank you
Yes,
so
ma'am.
much. That clears it up.
Okay. All right. So I'm going to go ahead and pull up part of the lecture to go over. But first, I want to just take a personal moment to thank those of you that have reached out to me during the last week or so. Things have been a little bit tough, and I just want you to know that I appreciate all of your comments. It means a lot, and I really do thank you for those words of encouragement that some of you have sent my way. All right. Okay. So let's talk a little bit about fluid and electrolyte imbalances. There are many reasons for fluid and electrolyte imbalances. Your book gives you just a few. Burns, which cause fluid shift, heart failure, which causes fluid accumulation, and then therapeutic measures like the prep for a colonoscopy, where you give somebody laxatives that cause diarrhea and cause them to lose fluid and electrolytes, or the use of diuretics. So those are just a few. I do want you to understand the different compartments of fluid and what you need to understand about those compartments. So you have your extracellular fluid volume. So what is extracellular fluid?
Outside of the cell?
Okay, outside of the cell, yeah. So it would be in your tissues and in your vascular space. So extracellular would be anything that is not in the cells, okay? And we'll talk more about this extracellular fluid volume balance, but I want you to understand that you have three components, three compartments. And in those compartments, you can have fluid volume deficit and fluid volume excess. And so this chart just kind of gives you signs and symptoms of fluid volume deficit and fluid volume excess. Now, the space, and this is really important, the space that is the highest priority for you and your patient is the vascular space. So the vascular space, we have to manage the vascular space as the priority. Because if we don't, we won't be able to manage anything else. So we'll talk a lot more about the vascular space next week when we do perfusion. But that vascular space is what's inside of your vessels. And so it contains blood cells, fluid, electrolytes, water and plasma, lots of different components that make up the blood. But the majority of your blood is water. So when the amount of fluid in your intravascular space increases or decreases, then your patient's going to start showing symptoms of either fluid volume deficit or fluid volume excess. So if we're looking at this table and you see the fluid volume deficit where it says hypovolemia, and you look at the signs and symptoms for mild fluid loss, you see orthostatic hypotension and increased heart rate. The orthostatic hypotension comes from you not having enough fluid in the vascular space to maintain your blood pressure. So orthostatic hypotension is what happens when you don't have enough fluid in your vascular space to maintain your blood pressure. Now, when that happens, you see this symptom of increased heart rate. The heart will increase in the rate that it pumps to try to produce more pressure. Unfortunately, most of the time that compensatory mechanism of the heart does more damage than it does good, because when our heart rate increases, then we use more oxygen. And with our blood pressure being low, we can't circulate the oxygen. And so what happens is your heart needs more oxygen than what it can supply by pumping. And your patient will wind up having heart damage or heart failure or a myocardial infarction, because the heart's just working too hard to try to circulate blood when there's a deficit in how much blood is there. Now, with moderate fluid loss, you see their urine output will drop off. So remember that 30 mils per hour is the lowest normal level. We like to see it above 30. So there's nothing wrong with it being above 30, as long as you're not, having a ton above 30. And you would know that somebody was diuresing too much if their urine was colorless or very, very light yellow. So not only do we want to see it more than 30, but we want to see it that straw color as well. So when we have fluid loss, obviously we don't have the fluid to produce urine. So our urine output is going to drop down, and the urine is going to become more and more concentrated. Other things that we'll see is a very rapid pulse. The patient will become thirsty because that thirst response will try to tell the patient that they need to drink. And then with severe fluid loss, we see major problems that can result in cardiovascular collapse and death. And so that is usually from just a blood pressure that's too low. So people who get heat stroke or who have severe diarrhea or severe vomiting, they can progress toward severe fluid loss very rapidly, and we would start to see some major problems with their heart rate and their blood pressure. Now, conversely, your fluid volume excess or hypervolemia is where you get more fluid in your vascular space than what it can hold. And you want to remember that your vessels are semi-permeable, meaning that when the pressure gradient exceeds a certain point, those vessels get stretched such that fluid and other things, red blood cells and electrolytes and other things, can start to leak out of those vessels into the surrounding tissues. And so some of the things that we'll see there, you see the tachypnea and dyspnea and crackles. That typically comes from fluid overload or left-sided heart failure that produces hypervolemia. And in those situations, what will happen is that fluid will leak into the lungs. And so you hear adventitious lung sounds that typically are expressed as crackles, and your patient will have trouble breathing. If you look down here where it says pulmonary edema, that's basically what we're referring to. So you have that dyspnea or shortness of breath, crackles, often called rales, which signify fluid accumulation in the lungs, and then orthopnea. And orthopnea is a condition where a patient can't lie down and breathe very well because the fluid, when we're sitting up, any extra fluid in the lungs kind of goes down to the bottom of the lung. But when you're lying, it kind of spreads itself out throughout the whole lung field and causes the patient difficulty breathing. And so that's why we see the orthopnea. So that means that they can't lie down and breathe at the same time. And then for that fluid that's not leaking out of the vessels, that's still in the vessel, you'll see those distended neck veins and hand veins. You'll see jugular venous distension, which is where your jugular vessels in your neck protrude out and you can see them. Normally, we don't see them. If you put the patient at 45 degrees in the bed, that's where you want to assess for those neck veins. So you put your patient at 45 degrees and then you look to see if they have bulging jugular veins. With hypervolemia, we also see rapid weight gain. Most of these patients will be on daily weights, strict I's and O's. And for some of them, we may even measure abdominal girth to see how much fluid they're accumulating in their abdomen. So fluid volume deficit and fluid volume excess, you just need to kind of know the differences. You can
Ms.
think
Heyman,
about it.
I have a question.
Sure.
For fluid volume excess and with the lungs filling up with fluid because the vessels are stretching out and everything, how come you see, and I could be wrong, how come you see dehydration in those patients, like decreased output as well?
Good question. Most of the time, what happens there is that the fluid may not be in the vascular space. What happens is it leaves the vascular space to form ascites or peripheral edema. And so if it's not in the vascular space, then it's not going through the kidneys and the kidneys aren't removing that extra fluid. So you oftentimes will hear somebody talk about a patient third spacing. And so what that means is that the fluid is going in other spaces than what it's meant to go into. So it leaves the vascular space. Well, the way we make urine is when the blood flows through the kidneys at the glomerulus, then the kidney decides how much fluid our body needs to stay hydrated and how much fluid it needs to excrete to cause homeostasis. And so if that fluid is outside of that vascular compartment, then we don't have any way for it to perfuse for the kidney and the kidney to remove it. So their urine output will drop.
Got it. Thank you.
You'll also see in trauma patients or patients with bleeding, when their blood pressure drops, then they're no longer able to perfuse their kidneys. And without perfusion of the kidneys start to fail. And so their urine output will drop off as well. All right. Okay, so in dehydration, you can see changes in your patient. You have to understand that the major electrolyte that has to do with our hydration is sodium. Now, what do we call salt?
Sodium chloride.
Sodium chloride. So what is sodium chloride?
Sodium and chloride ions.
Compound.
Okay, it's a sodium chloride mix where sodium ions have joined, the positive sodium ions have joined with the negative chloride ions to form an ionic complex. Now, we think of salt as the same thing as table salt, which is sodium chloride. But any of our electrolytes that hook up with chloride would make a salt. So you have magnesium salts, potassium salts, sodium salts. So I don't want you to think that all salt is sodium chloride. The salt that we know and the salt that is what controls most of our water balance in our body is sodium chloride. But not all salts in our body are sodium chloride. There are other types. So as we go through and we talk about these different electrolytes, you have to understand that all of them make salts within our body. All right, I'm not going to talk about assessment of skin turgor. Y'all learned that last semester. And this is just a little visual in case you're a visual learner of what fluid volume excess looks like. Patients will report feeling heavy and they'll be coughing and maybe have a productive cough. Anytime your fluid level gets too high or too low, your patient's neurologic status is going to be affected, and so the patient will be at risk for seizures and changes in the level of consciousness, confusion, irritability, all of that stuff. Okay. And y'all learned this last semester again in your assessment, but you can determine how much edema somebody has by pushing your finger in their skin and seeing how far it indents and stays. Okay. This is a picture of jugular venous distension. So you see the jugular vein here that is sticking out that normally should not stick out. What that means is that vessel is just full. It has so much more volume in it than it should have, so it bulges out. You can kind of think about fluid volume as a water balloon. Your vessels are a closed system, kind of like a water balloon. So if you have too little water in a water balloon, you're not going to have any pressure to do anything with it. It's going to be floppy. But if you put too much water in your water balloon, what's going to happen?
It's gonna bust.
Yeah, it's going to burst. And our vessels are the same way. If we don't have enough fluid, it's a closed system. So it's like one great big major system of a closed balloon. If you don't have enough fluid, then your vessels are going to collapse and you're not going to be able to perfuse your blood. But if you have too much, then the vessels could rupture, just like that water balloon, causing a stroke or a hemorrhage somewhere. Or it could cause increased intracranial pressure in the head, or other problems from the vessels just being too full. So remember that your vascular system is a closed system and that you have fluid fluctuations that occur within that closed system. Okay, so nursing management of fluid volume, we're going to look at a lot of different things. You want to check your lab values, especially your your basic metabolic panel, which is going to consist of sodium and chloride and potassium, CO2, or bicarb, depending on where you are, your BUN, your creatinine, and your glucose. by looking at most of that panel, you can kind of tell what's going on with electrolytes and fluid. For example, when your BUN or blood urea nitrogen goes up, that's usually due to a fluid deficit. So think about this. You have nitrogenous wastes in your body, and your BUN is a measurement of the concentration of nitrogenous waste, specifically urea. Well, if you get dehydrated, then you're going to lose fluid, but the particles that are in the blood are going to stay elevated. And so that blood urea nitrogen is going to go up. Now, renal failure, on the other hand, will make that blood urea nitrogen go up because the kidneys can excrete the urea. So there's more than one reason why a BUN might go up, but most of the time, if you have a BUN that's increased, then you're dealing with fluid loss. And we're going to talk a little bit about the hematocrit. I want to make sure that you understand it. And then your both your blood and your urine osmolality will change. What is osmolality?
The pressure.
The movement of water.
If we get an osmolality value, what is that telling us?
The concentration of
Yeah,
water.
concentrate.
Okay. Yes, the concentration. So your osmolality is the number of solute particles in a solvent. I don't expect you to know osmolality and osmolarity per se. I just want you to know that both osmolality and osmolarity have to do with the concentration of the blood. How many particles are in a certain measurement of fluid? Now, when we have somebody who is fluid deficient, the interventions for you as a nurse are listed over there on the right-hand side. So we want them on strict I's and O's. And strict I's and O's means you measure everything that goes in and everything that comes out. So if they have liquid stool, that's a measurement. If it's a solid stool, it's not. If they vomit, that emesis should be measured. If they drink 30 mils to swallow a pill, that 30 mils goes in that count. So strict I's and O's mean you try to check every single little bit of intake or output that they have. Then you're going to look at their lab values. And the three that are listed there are your electrolyte panel, which goes up when somebody's dehydrated and goes down when somebody's overhydrated. Your complete blood count, which the number one value off of that complete blood count that you're looking at is the hematocrit. And then urine specific gravity. Because when somebody is dry, what's going to happen to their specific gravity?
It'll increase.
It'll increase. Because remember that specific gravity is just telling you the concentration of the urine. The higher the specific gravity, the more concentrated your urine is. And the lower the specific gravity, the more dilute your urine is. And then you're going to assess the respiratory system. Make sure you're listening to their lungs for adventitious lung sounds. Do your neuro checks to pick up on changes Check for weight changes. Like I said earlier, these folks are going to be on daily weights. And remember that when somebody gets dry, when they have fluid volume deficit, they're more likely to develop skin breakdown and breakdown of their mucous membranes, because once tissues are dry, then they tend to break down. Our tissues need oxygen and nutrition and fluids to be healthy. So whenever somebody gets fluid deficient, then their cells are not healthy and those cells can begin to break down. You also want to remember that your hydration, your body water, and when I say water, I'm talking about all of those non-blood cell fluids that are in your vascular space. Your body water is just like the coolant that you put in your radiator in your car. So we need to be well hydrated for our bodies to be able to cool correctly. And when they can't, then our body can start to overheat. Now, for mild dehydration, you may see a temp that goes up a little bit, but usually doesn't breach 100. But you will still see little temps. And a common thing that you'll see that with is somebody that comes out of the operating room, and during that first 24 hours, while we're trying to rehydrate them and replace fluids that they didn't get when they were in PO, or that maybe they lost during surgery, they may run a little low-grade temp. And that tells us that they're kind of a little bit dehydrated. Now, we're not going to see a temp that shows infection usually until after the first 24 hours. But during that first 24-hour period, if their temperature goes up just slightly, that's an indicator that they need a little bit more fluid. So think about that fluid as your body's coolant. So with fluid volume excess, you're going to listen to those lungs, measure that I and O. Anytime you've got somebody on IV fluids, you need to be listening to their lungs and checking their blood pressure. And before you ever hang IV fluids on a patient for the first time, you want to listen to their lungs as well and make sure that those lungs are clear. You can't give IV fluids to somebody that has a bunch of crackles in their lungs because they're already fluid overloaded. And if we add more to that, then we can fill their lungs up with fluid and they can die from that. So in this slide, this is talking, it talks about how we manage our fluid. And remember that where it says extracellular, you're talking about the vascular and the tissue spaces. And the vascular one is the one that you want to pay attention to. So we will give IV fluids and meds as ordered. But like I said, you need to do an assessment first. And there where it says monitor patient for effectiveness of therapy. How are you going to know that a patient who was in fluid deficit is responding?
Labs.
Specifically?
So if they're in deficit, their blood increased back to like a normal range or closer to a normal range.
Okay.
And then specific gravity of the urine.
Okay.
And then just everything kind of normalizing your electrolytes maybe from whatever IV fluid you're hanging.
Okay. So we're going to see urine output increase, and we'll see the urine go from a darker color to a lighter color. If we get a urine specific gravity, it will have gone down because it's no longer as concentrated as it was. You are correct that your BUN is going to fall because you have more fluid to excrete that urea that is building up in your blood. Blood pressure will normalize. Heart rate should normalize. And you should be able to look at the electrolyte levels and see how they've trended together. Now, I'm going to take this opportunity to talk about two situations in the body. All right. So can y'all see the whiteboard?
Yes, ma'am.
Okay. We have hemodilution and we have hemoconcentration. All right. These two terms, y'all, are used when body water changes, either loss of fluid or gain of fluid changes the overall consistency of the blood. So in hemodilution, we have increased fluids or fluid excess. And with hemoconcentration, we're going to have decreased fluids or fluid volume deficit. So let's just say that we have a normal potassium of 4.2. So when we measure the labs and we see that they're normal, for the most part, we can say that our patient's fluid status is probably stable. But then when we look at hemodilution, if our patient has too much fluid in the vascular space, then we have more fluid. And so we don't have less particles. The particles that were there at 4.2 are still there. But because we've added more fluid and we've diluted that blood down, now our potassium level might be 3.4. And if we correct their fluid balance, then they'll return to around their 4.2. With hemoconcentration, what does hemo mean?
Blood.
Blood.
Blood. So we have blood dilution and blood concentration. So with hemoconcentration or blood concentration, fluid has been removed. So what may happen is that 4.2 for our potassium level would then go up to maybe, I don't know, 5.3. So the amount of potassium that we had really didn't change. What changed was that we lost fluid, and so the blood became more concentrated. Does this make sense?
So you're saying that the dilution is like watered down blood?
Yes.
Okay.
So let's say that you are making a pot of soup and you left it on the stove with no lid on it, and it was simmering, what's going to happen to your soup?
It'd get concentrated.
Okay, yeah, because steam is going to form and come off of the soup, which is water that's in the soup. So you're losing the water. Now, your soup is then going to become thicker. And is it going to taste too strong or too weak?
Strong.
Strong. That's right, because the fluid that was in that soup is gone. And so it will make it more flavorful because it's less dilute. Now, let's say you say, oh no, I don't want my soup to burn and it's too thick, so I'm going to add some water. So you add water and it becomes really thin. How's it going to taste?
Watery.
Watery.
Bland.
Yeah, bland, because you've watered down the soup. And so in order for the soup to taste right, not only do you have to add water, but you have to add a little bit more seasoning too to make it taste normal again. So do you understand the difference between hemodilution and hemoconcentration and when you would see those things?
Yes, ma'am.
Yes.
So if somebody comes in with a potassium of 5.3 and their urine's dark and concentrated and their skin turgor's poor, their mouth and their eyes are dry, then we know that they have fluid volume deficit. So if we start to hydrate them with IV fluids, as that hydration helps them return to normal, then we're going to see all of their labs go back to normal. So you're not going to have normal labs and electrolytes if a patient is either overhydrated or dehydrated because the concentration is not correct. So they have to be hydrated well without being overhydrated to make sure that everything is stable. Now, we measure hydration a lot of different ways. We measure it by turgor. We measure it by urine output. We measure it by blood pressure. We measure it by specific gravity. What else?
What is after turgor? What is that? UOP?
UOP is urine output.
Okay, thanks.
The urine color.
Okay, urine color. So we can put amount. We can put color. We can look at heart rate. We can look at temp.
Could you look at the
Yeah,
blood
lungs.
pressure? Oh, it's up there. Sorry.
Could we look at what?
Sorry, it was already up there.
What's that?
The blood pressure.
Okay. So we can look at a lot of things. But what I want you to learn is the best way to look at fluid volume in a patient where you have the labs that you can do so. You know, if you just, let's say that you were leaving a restaurant on a hot summer day and there was a gardener outside that had been tending to the plants and stuff at the restaurant, and he's on the ground. If you go over to him to try to render aid and you look at him and his skin is hot and dry and his mucous membranes are dry and his pulse is very thready, meaning it's not strong and it's rapid, you can make a pretty quick assessment that he is dehydrated. And so you could say preliminary wise, he's dry. He's got heat stroke or he's dehydrated. He hadn't been drinking his fluids while he's been out here working in the sun. And so we're going to see hypotension, tachycardia, dry, hot skin, dry membranes, poor turgor, all that good stuff. But if you have labs, there's one particular way that you can evaluate fluid status that is more reliable than just about anything else. What is it?
So you
Is it
get-
your hematocrit?
Hematocrit.
The hematocrit. That's exactly right. So let's talk about the hematocrit. Now, I will tell y'all that I'm a stickler for labs because labs will tell you more about your patient a lot of times than anything else. And I think if you learn to understand them, then you become a better nurse. And probably if you went to a clinical area and asked the nurses to explain hematocrit to you, a lot of them couldn't do it correctly because they were never taught to look at the hematocrit or any other labs for that matter. Now, your common labs, sure, but like D-dimer, a lot of them can't tell you what a D-dimer is for. D-dimer is for, we use it to look at bleeding diathesis, and we use it to look at the presence of like pulmonary embolisms, because a D-dimer measures how much clotting your body is doing. So if your body's clotting enough to cause pulmonary emboli, then you're going to expect your D-dimer to be elevated because there's clotting going on. But the hematocrit is kind of interesting, and it's a great way to tell about your patient's fluid status. So what is a normal hematocrit level?
12 through 16. Oh, I'm sorry.
36 to
6
48.
through 48.
All right. So let me show you a quick and dirty way to remember it. Your hemoglobin is 12 to 16. Some people will say 18. I personally don't like going up to 18 because I'll show you why when we talk about the hematocrit, why I don't think it should be that high. To get your hematocrit, the ratio between hemoglobin and hematocrit is 3 to 1. So if we take our hemoglobin, 12 is normal. We multiply it by 3, we get 36. We multiply 16 times 3, we get 48. So, and that's measured as a percent. Now, what is the percentage? What's another name for percentage?
Concentration.
Something out of 100?
It's a ratio
Ratio.
of X to 100, right? Does that make sense?
Yes,
Yeah.
ma'am.
So you know if you have 100% of anything and it has parts, each part is going to have a ratio. And so that ratio is figured by X over 100. So your hematocrit is a ratio and it's expressed as a percentage. And if you remember that percentage, that makes it a little bit easier for you to understand. So on your test, you're bebopping along and you come to a scenario that has a hematocrit in it, and you can't remember what a hematocrit is supposed to be. All you have to do is take the normal hemoglobin, which everybody remembers, multiply it by 3 on the high end and the low end, and that will give you your range for hematocrit. So if we went to 18 here, that would make our hematocrit a 54, I believe, or 52. 18.
52.
That'd be
52.
54.
Okay, so 54. Well, when you understand what a hematocrit is, you understand why 54 is a little high. So let's talk about a hematocrit. So we're going to have a vacutainer tube that has 10 mils in it. Okay. There's 10 mils. All right. Our hematocrit is 40%. What that's telling us is that our cellular component is 40% of our blood. Well, if the cellular component is 40%, what is the other 60%?
Water.
Fluid, yeah, water. Absolutely. So what this would look like in a picture is, you know, when you draw a vacutainer tube and you let it sit, the water's going to come to the top and the cells are going to go to the bottom. And that's one of the ways you can measure hematocrit. So we're going to say that 4 mils of our solution is cellular component. That's 40%. So 4 milliliters of 10 is 40%. So we have 40% cells. So is that normal?
Yes.
Yes.
It is, because it falls between 36 and 48. So what that's telling us is that our water here is sufficient when compared to the amount of cells that we have. So our ratio of water to cells is appropriate so that that patient is well hydrated. Now, let's switch this around and let's say that our hematocrit is 60%. So that means we're going to have 6 mils of cellular content and 4 mils of water. What happened to our concentration?
It's more concentrated.
More concentrated, got thicker.
Exactly. So it's more concentrated and it got thicker. So the blood is more viscous. Now, which one of those scenarios is going to make it easiest for the heart to perfuse the body?
The first one.
40%.
Yeah. Yeah, when we have 40% cells and 60% water, that means we have enough water to dilute our blood to the appropriate concentration so that we're maintaining a homeostatic level of electrolytes and everything else and that we have enough water to circulate it. Whereas in the scenario that's on the screen now, if we have 60% cells and 40% water, our blood's really thick. And in order to make that blood move better, the heart has to work harder. Well, what is the heart?
Muscle.
It's a muscle. So if you go to the gym and you're lifting, I don't know, 120 pounds, your muscles are going to kind of stay at that 120 pound level. But what happens if we boost you up to 150 pounds?
The muscle's going to grow.
The muscle's going to grow, which is what you want if you're going to buff up, right? And that muscle grows because you have minute tearing from lifting that weight. And as the body repairs it, it gives you more muscle mass. So you wind up buff. Well, that's great as long as it's like skeletal muscle. But when you have a heart that has to push hard blood, we're going to say this is our atrium, okay? And our atrium is used to having this fill space. And to get our cardiac output, our atrium contracts and pushes the blood out. And that's how we get our cardiac output. Well, if our heart is made of muscle and we ask it to do more work than it really needs to be doing by pushing blood that's too viscous, or by trying to push blood that's missing if they're dehydrated, that muscle's going to enlarge. But it's going to enlarge so much that it's going to decrease the fill space. So that's going to be put out as cardiac output. But how much cardiac output do we have now compared to what we had? It's gone down a good bit, right? And so as our heart tries to circulate blood that's heavier, then what it does is it damages the cardiac muscle, and the cardiac muscle repairs and grows, but it impinges on the actual part inside the muscles where blood can come in and be pushed forward with a pump of the heart. So what we wind up with is cardiomegaly. Well, it's not wanting to write right there in that one spot. So cardiomegaly is when your heart increases in size because of trying to pump too much or whatever. And it decreases the amount of blood that your heart can pump in a single contraction. So basically, if we go back and we look at our hematocrit again with our 10 mils of blood, we can tell more about our blood because it's showing us a specific ratio. So if we know we have 100% and our hematocrit is 40, we know we have 40% cells and 60% water. And 60% water, as long as the heart's healthy, can circulate 40% cells any day of the week. But if we change that up and we have 60% cells and 40% water, that heart's going to have a hard time. What else is going to happen outside of the heart to that blood?
It's going to be hard to go through any vessel because it's
Okay, so it's going to have difficulty perfusing all of our body. And what else? What happens when blood moves slowly?
Does it clot easier?
Absolutely, it
edema.
does clot easier. So patients who are dehydrated are at high risk for having embolisms because the blood gets thicker and it can't move through the vasculature as rapidly as it should be, and it's not diluted the way that it should be. And so those cells start to clump together and cause clots. So as your hematocrit becomes abnormally high, your patient becomes more at risk for clotting. So I want to stop right here and just see if you have any questions thus far. And I need to make sure that you understand the hematocrit.
I have one question.
Okay.
So if you have a high hematocrit, the cardiac workload increases, but the output decreases?
Yes, absolutely.
Okay. Thank you.
Yeah. And so our goal is to help our patient maintain adequate fluid balance by making sure that their hematocrit is what it should be. Now, there are two variables that make up the hematocrit. You have the cells and you have the fluid. And this is a lecture for another day that you'll get in another course. But we're looking at this for this particular lecture from the standpoint of changes in water. Water decreases, the hematocrit goes up. Water increases, the hematocrit goes down. But we also have to remember that we can have the appropriate water content and the cells can change. For example, what happens in anemia?
It's low red blood cells.
Okay, your red cells decrease. And so if your red cells are decreased, your hematocrit's going to go down, and it's going to look like you might have too much water. But in that case, you don't have too much water. You just don't have enough cells. So I won't ask you anything about that on this test. And I won't really expect you to know it. But I do want you to realize that when you have two variables, cells versus water, a change in either one is going to make a change in the other. But for the purposes of this lecture, you need to know that if somebody has a hematocrit of 28, what does that mean?
Fluid
That is
excess.
watered down.
Yeah, they have more water than they have cells. And so their blood is too dilute. And when it's too dilute, then we have hemodilution.
Dilution.
So you're going to see electrolytes that appear too low. But if we can bring the hematocrit back to normal, guess what? If it's just hemo concentration, then as the hematocrit normalizes, everything else will normalize with it.
I do have a question. So our first go-to is the hematocrit levels, and then we will go to like the sodium, the potassium, and okay, all right.
Yeah, because sodium and potassium and all of your electrolytes and other components that we measure in the blood can change for many different reasons. But if your hematocrit is altered, then you know that, at least in part, your electrolytes and labs are going to be altered until you get that hematocrit fixed. So if the hematocrit is too high, as in this case right here, how do we fix it? What are they missing?
Fluid.
Fluid. So we give them fluid. If it's mild, we'll push PO fluid. If it's not mild and more severe, then we'll give them IV fluids. Now, what if they're overhydrated, where we have, let's say we have a hematocrit of 24. What does that mean our water is? Let's see, 76.
So that would mean that the blood is watered down and we would need to see what we need to replenish as far as electrolytes.
Or in most cases, if all of the electrolytes are abnormal, we know that we just have too much water and we need to get rid of some water. So we might give a diuretic.
Okay.
To remove that water, bring that hematocrit back down to normal. And then we know that we're no longer hemoconcentrated or hemodiluted, and that we're looking at a true picture of our blood. And then we would look at our electrolytes. In other words, as long as your hematocrit is abnormal, your electrolytes and your blood panels are going to look abnormal. But once you fix that fluid balance, then those electrolytes and all should correct. If they don't, then you can start with either getting rid of electrolytes or adding electrolytes. Does that make sense? So you got to make sure.
So you're saying we need to fix the hematocrit before anything else?
Yeah, because
Okay.
if your hematocrit is not normal, whatever you're seeing in your labs is going to be false until you get the water balance in the body back to normal.
Okay, thanks.
Okay. All right, enough of that. Let's move on. Y'all can look at that. Your book has a lot of stuff in here that's helpful, but y'all can go back and look at the nursing diagnoses. All right, so now we're going to talk a little bit about fluids. And I'm going to go back to the whiteboard because I just think I can do it better with the whiteboard. All right, what does tonicity mean? It has to do with the osmolarity and osmolality of the blood. So in order to understand fluid therapy, you have to first understand tonicity. So basically, tonicity is the percent solute in a ratio with solvent. So solute is particles or water?
Solute is particles.
Okay, so yeah, we have our particles here, and we have our water here, basically. All right. The body's tonicity, and put this in your brain, remember it forever and ever. because everything is going to be measured against the body's normal tonicity, and that is 0.9%. So what that means is that the tonicity of our blood, we have 0.9% solute in 99.1% solvent. Now, don't ask me to explain it, just accept it for what it is. That is what human blood is, 0.9%. So when we talk about 0.9%, that is called isotonic. Anything that is 0.9% is isotonic. If it's greater than 0.9%, it is hypertonic. If it's less than 0.9%, it is hypotonic. So this picture right here is critical to you understanding what we mean when we say something is isotonic, hypotonic, or hypertonic. So a hypertonic, huh?
You said that was in the vascular space, correct?
Yes, we're talking about the vascular space. So if it's hypertonic, it has increased particles that are more than 0.9%. If it's hypotonic, we have decreased particles. All right. Any questions before we move to the next step? Because if we go on to the next step and you aren't with me here, you're going to be double lost.
So it doesn't matter about the water, it's just about the particles?
Well, but the particles are in the water. We just measure the tonicity by the number of particles.
Okay.
But remember, it's a ratio.
Right.
Okay. All right. So with that being said, an isotonic solution stays where you put it. All right. So how do we give isotonic solutions? IV.
IV.
And what does IV stand for?
Intravenous.
Intravenous or intravascular. So we put our isotonic solution in the vascular space. It's going to stay there because we are given something that is 0.9% into another thing that's 0.9%. So they're equal. No adjustment has to be made. Okay, so with an isotonic solution, we put it in the vessels and it stays in the vessels because 0.9% plus 0.9% equals that stable 0.9%. And when you think about it, the reason it does that is because when we're adding those fluids in, we're adding the exact same concentration of particles in water. So it increases the volume, but it doesn't change the tonicity. So if you put apple juice in apple juice, you still got apple juice. But if you put apple juice and water, when you drink it, have you still got apple juice?
Yes.
Oh, ma'am, it's water.
It's watered
Water.
down.
Water
Apple
down apple. And it's not going to be the same. So in an isotonic solution, you're adding same to same. So the concentration, the taste, if we're talking about our apple juice, is going to stay exactly the same. All right. So let's talk about hypotonic. Hypotonic fluids are less than 0.9%. So in order for a hypotonic fluid to become isotonic, because remember, our body keeps everything at 0.9%. So if we give somebody a hypotonic fluid, how does our body make it 0.9%?
It's just
What's it missing?
out of the cell.
Missing more particles.
It's missing particles. So it's got to find particles. It's got to leave a lower concentration and go to a higher concentration. What word describes that?
Diffusion.
Osmosis.
Well, you have
Oh, yeah.
osmosis and you have diffusion. Osmosis is the movement of water. Diffusion is the movement of particles.
But the
Well, if
particles
I
aren't
put-
going to move through the membranes. So wouldn't it be osmosis then?
Exactly. It would be osmosis. Because we don't have any particles in the blood that are extra. It's 0.9%. So in order for this hypotonic solution to acclimate to that 0.9%, it needs more particles. Well, it finds particles in the cells and the interstitial space, which is like the fluid filled cushiony space in between everything in our body. Okay, it's outside the vascular space.
So it basically pulls it into the vascular space?
Nope.
It'll leave the vascular space to until it makes equilibrium again.
Okay. And equilibrium is a great word to describe it, because equilibrium means it has found a way to become 0.9%. So in order to get more particles, the water has to leave and go find them. So think about hypo will go. So it leaves the vascular space and goes into the interstitial space and the cells, where it can find enough particles to achieve that equilibrium of 0.9%. So if we give hypotonic fluids intravascularly, intravenously, it won't stay there. It's going to move out into other parts of the body.
How do you know whenever it's too much? Like, wouldn't it cause swelling or edema?
Yes. If you gave somebody who was, let's just say that all in all, they were normal, we were just going to hydrate them. They were NPO for surgery. So we were going to hydrate them, okay, to keep them where they need to be. If you give them a hypotonic fluid, it's going to cause fluid shifts from the vascular space to the extravascular space, and it will cause edema. So, who is that was speaking?
So if you give hypotonic solution, because they need particles, they will go into the cells and the spaces to find the particles. So they will leave the vascular space.
Correct.
Okay.
Because there's not enough particles in the vascular space to hold it there. So it's going to go out and find those particles. So give me an example of a patient that would benefit from a hypotonic fluid.
Maybe like metabolic encephaly or something, like where it's the electrolytes are high and like the brain builds up and stuff. So then would it pull it from that, I guess, or would it?
If you had somebody with high electrolytes,
Where it's like built up in the cells, and then would it pull it from the cell?
it would pull the fluid to the cells and dilute the cells.
Okay. Okay.
So a good example would be somebody that was severely dehydrated. Let's say somebody with heat stroke. We would have to fill their vascular space first, because remember, we always have to take care of the vascular space first. But after we replace the fluid in their vascular space, then we would have to replace the fluid in their extravascular space. So think about it this way. Here's a cell. We give isotonic fluid. Cell's going to stay the same. Okay? With dehydration, we have a cell that's kind of dry, right? It's lost some of its fluid. It's not nice and fat and round and pretty. So we give hypotonic. It's going to put it back like it should be. Now, when we have hypertonic, think about this cell being so full that the membranes just about can't hold all the fluid, and the cell's about to burst. Let's say that we do have that peripheral edema, and that's what our cells look like. We wouldn't give them isotonic because it's not going to do anything for that edema. We wouldn't give them hypotonic because that's just going to put more fluid there and those cells will rupture. So what we need to do there is to give them hypertonic. And what that's going to do then is pull water out and bring the cell back to normal. Does that make sense?
Is the water going back into the vascular space?
Here?
Yes.
Yes. And I'm going to talk about that. But I wanted to put this up here so that you see the effects on the cells and the blood from the different types of fluid. So isotonic, everything stays the same. We're just adding more of the same concentration. It's all equal. It all stays the same. There are no fluid shifts. However, when we get hypotonic, the fluid's going to leave the vascular space and go into the cells and interstitial space and refortify it. Then when we have hypertonic, we have increased tonicity. So let me give you the example that you see most frequently if you're talking about really needing to manage somebody's fluid. We can give them 3% saline solution.
So would like a patient on dialysis, for example, benefit from getting hypertonic solution during their dialysis treatment to pull the water in so that it can be dialysized and stuff? Or
Well, that's going to depend on what kind of dialysis you're talking about.
like if they had fluid overload and like, pedal edema and everything,
Okay.
is
With
that
that
like
kind of dialysis, they're going to have hemodialysis. And in hemodialysis, we're not going to use fluids, but what we're going to do is take their blood out of their body, run it through a circuit that contains an artificial kidney that's going to filter out water and waste, and then it runs back into the body. Now, with peritoneal dialysis, that's a whole different critter, because with peritoneal dialysis, you're instilling fluid into the abdominal space. And when we instill that fluid into the abdominal cavity, it's going to pull out wastes and some water, not a lot, but some water and mostly wastes into the belly. And then we drain it off with a catheter. So the tonicity of the fluid for peritoneal dialysis is going to depend on what we want to do. But if we're trying to just remove wastes, then you put a certain tonicity in there and it pulls the waste out of the blood, because the waste can move through that semi-permeable membrane into the fluid that's in the belly. And what it basically does is it just pulls it out of the blood into the belly, and then you drain it out in the trash. If it's hemodialysis, we don't use fluid. We just use an artificial kidney.
Okay, thank you.
Yeah. All right, so with hypertonic, 3% saline, how does that compare to isotonic?
It's way higher.
It's way higher.
Saline is
Okay.
0.9.
Yeah, so if we're looking at 0.9% versus 3%, 0.9, yeah, it's very concentrated, but think about it. 0.9 is what you would taste in your tears. So I'm sure everybody at one time or another has tasted tears. It's a little salty, but not a lot, just a little bit. Now, what if you go out into the ocean and you get ocean water in your mouth? Is it just a little bit salty?
Very salty.
Yeah, it's enough salt that'll make you puke if you're not careful, right? It's just so salty. That's the difference between 0.9% saline and 3% saline. It has a ton more salt. So it's very salty. So we said that iso stays where you put it. Hypo will go, but hypertonic, think about it, it parties in place. So it stays in the vascular space where we put it. What does it need to become 0.9%?
It needs some of the particles to
Fluid
leave.
out of the cell.
Okay, so we could say that it needs particles to leave, but we could also see that it needs water. So what happens when we give a hypertonic solution? Remember,
Water
we
is pulled into the
said
vascular space.
took these cells that look like this that we're about to burst, and it makes them normal because it pulls fluid into the vascular space. So with hypertonic, we're pulling fluid into the vascular space. With hypotonic, we're pushing fluid out of the vascular space. So it's just the reverse.
Would giving someone hypertonic who's already fluid overload, would this increase their blood pressure?
Oh, absolutely.
So we would
It
give like a diuretic most of the time, or?
Yes, absolutely. So an example of a patient that you would use this for, let's say that we have somebody with 4+ pitting edema. So they have a lot of fluid in their cellular and interstitial space. And it's irrelevant to what their vascular space is because we need to get that fluid out of there. So if we give them a hypertonic solution, that's going to shift the fluid into the vascular space. If the vascular space is deficient, meaning the patient's dry, that's going to pull fluid in and replace the fluid that they've lost out of their vascular space. But if their vascular space is normal or it's already full and we pull more water in, they're going to be too full. So their blood pressure is going to go up. They're going to have signs of fluid overload. Well, in order to get that fluid out, then we would need to give them a diuretic to help the kidney get rid of it. But if we don't pull it back in the vascular space, will it go through the kidney for filtering?
No.
Ma'am.
So do you see that we would use the hypertonic solution to shift fluid from outside of the vessels into the vessels so that then as it flows through the blood into the kidney then will get rid of it. So when I use the term parties in place because if you're throwing a party, do you go somewhere else or do your buds come to you?
They come to you.
Right. So if you're throwing the party, all your friends come over. Well, in a hypertonic solution, we put it in the vascular space, and what it does is it pulls all of its water friends over into the vascular space. Now, that can be a good thing if you need more water in your vascular space. It can be a bad thing if you don't need water in your vascular space. So in the example that I gave you, where you had a patient who had peripheral edema, if we pull all that fluid from that peripheral edema back into the vascular space, then the vascular space is going to fill up and become overhydrated. So what we need to do in that case is to help the body excrete it. And so that's when we would potentially give them a diuretic. Now, I'm going to mention this next statement just for teaching purposes, but I won't test you on it. If you have a patient who, for whatever reason, has a life-threatening deficiency of fluid in the vascular space, we will give hypertonic solutions to pull fluid from the interstitial and the intracellular spaces into the intravascular space to preserve life. And what I mean by that is when you have a patient whose blood pressure is low enough that it's not life supporting, and we have to get fluid into the vascular space quickly to bring that blood pressure up, we may use a hypertonic solution because that's going to flood the vascular space with more fluid. Now, once we get the vascular space stabilized, what's the condition of the interstitial and the intracellular fluid?
It's dry, over concentrated.
Yeah, it's decreased. So once we stabilize the patient, we would have to go back with a hypotonic and replenish where we robbed the fluid from to get it in the vascular space. Now, you need all three of your spaces, intravascular, intracellular, and interstitial, to be hydrated. But the one that you will die from the most quickly is a deficiency in the intravascular space, because that fluid in the intravascular space is what gives you your blood pressure. So if you are fluid deficient in your vascular space, your blood pressure is going to drop, and it can drop low enough that your heart can't pump and you go into cardiovascular collapse and you die. So that's why I want you to remember that out of all of the three spaces, we have to maintain the intravascular first, because if we don't, the other two won't matter. You're going to die anyway. Questions? Okay, so now we're going to talk about different types of fluid. And you will be expected to know what kind of fluid you're dealing with and which patient would be the most appropriate to receive the fluid that we're talking about. So let's just talk about good old 0.9% saline. And remember that saline is sodium chloride. So this is the easy one because we know it doesn't change anything. It goes in the vascular space and it just sits there because it doesn't need particles that it has to go find, and it doesn't need water that it would draw in. It's the same. So it just stays there. So we would give this maybe to a pre-op patient who's been NPO. So they aren't able to drink to maintain their hydration. So we want to make sure that they stay hydrated for their surgery. So we just give them 0.9, because all that's going to do is just make sure that they're hydrated, and it takes the place of what they normally would be drinking orally. Okay? Now, I've already showed you the example of the 3% saline, which is the hypertonic saline. But what happens if we were to give 0.45% sodium chloride solution?
It's still a hypersonic.
That's hypotonic.
Why is it hypotonic?
It's less than
Because it has less particles.
It has less particles. And you will oftentimes, instead of hearing it called 0.45% sodium chloride, you will hear it called half normal saline. Because 0.45 is half of 0.9. So these two are exactly the same. You may see it written either way. On the bag, it's going to say this, but your physician might order half NS. Same thing. Because whole normal saline is 0.9. So half normal saline would be half of 9, which is 0.45. And there is one, you have different concentrations. You can have I think it's 225%. We don't use that much. They use that more in pediatrics. But it does go down to a lesser concentration. So if we're going to give 0.45% or half normal saline, that's going to be hypotonic because it's less than 0.9. Okay? So when you're evaluating your fluids as to how they work in the body, look first to see if they have sodium chloride. All right. Now, sometimes we give a patient a fluid that is signified by W, and that stands for water. Now, sodium chloride or normal saline is water, sterile water, plus 0.9% sodium chloride. To make any fluid, we start off with sterile water. And then we just add to it what we need to make it isotonic, hypotonic, or hypertonic. Water in and of itself is hypotonic. So when you see W, you know that stands for water. Now, in the bag, and I'm going to go down here just to show you something. Where is it? I thought there was a picture of a bag in here. But when you look at a bag, it's going to have a label on it. And it's going to say what's in the bag. Well, if that bag is laying on the table at the bedside, what's it doing for that patient?
Nothing.
Nothing. Okay. I teach this a little bit differently, but I teach it differently because I think it's easier to understand. So for the purposes of my test, I don't want you to know what's going on that bag if it's laying on the table, because I don't care. It's not doing anything for my patient. What I want you to know is what's going on in the body once we infuse that fluid. So on a test question, it might ask you, it might give you a scenario saying, Mr. Smith is receiving D5 1/2 normal saline at 75 milliliters per hour. Once infused, this fluid will act by. Select all that apply. So I'm going to preface it with once infused. because that's only what we care about is what it's doing in the body once we put it in the body. Before it gets there, it ain't doing nothing. So I want you to pay attention to what's going to happen in the body. So when we give water, it's severely hypotonic. And the way you can remember that is when you go to your sink and you draw a glass of water to drink, is it salty?
No, ma'am.
Shouldn't
It
be.
shouldn't be.
Is it sugary?
No.
No, ma'am.
No. So if it's not salty and it's not sugary, then it's hypotonic. Because it doesn't have those particles in it. So anytime we have a W, you know that that base fluid is hypotonic. Now, it's going to get a little bit confusing, so I want you to stop me if you need clarification. Another primary component of IV fluids is dextrose. And base dextrose is 5%. So this is your glucose, sugar. And it tells you it's a sugar because it's right there, ose. All right. So if I have dextrose and I add it into a fluid, what is that automatically going to make that fluid become?
Sweet.
Isotonic, hypotonic,
Oh,
or hyper?
Hypertonic.
Okay. So 5% is greater than 0.9% any day of the week, right? And so that's going to make this hypertonic. However, when we put dextrose in IV fluids and infuse it into the body, the dextrose goes to the cells because insulin opens the cells and the dextrose goes in to feed the cells. And so the dextrose disappears from the vascular space. And so what you're concerned with then as to how your fluid is reacting in the body is by looking at what's left. So let me give you an example. If we have D5% dextrose in 0.9% normal saline, when we infuse it, once we put it in the vascular space, the dextrose goes away because it goes into the cells. And this is what the body nets from it. So this is what stays in the blood. So we had a hypertonic fluid that once infused did what?
Went into the cells.
It became
Becomes isotonic.
it doesn't stay in the cell. It doesn't stay in the vascular space. It goes.
The sugar goes out, but then 0.9% is isotonic. So it stays in the vessel.
Stays in the vascular.
So think about it this way. You can always just get rid of your dextrose and say, okay, what's left and how is that going to affect my body? So let's look at another example. We have D5% W.
So that's hyposonic.
Hypotonic.
Okay.
Because
The
the water
dextrose goes
stays.
away. Yes, exactly. Because the dextrose goes away and what we're left with is water. And water is hypotonic. So what's that water going to do?
Go into the
So
It's going to fortify the cellular component, right? So if I asked you, which of the following actions does D5W exert on the body? What two things should you tell me?
The sugar leaves the vascular space. And
Okay, so we're feeding the cells energy, right? By providing the dextrose. And then what was number two?
and then the hypotonic solution goes out to the cells.
So we are fortifying the cells and the interstitial fluid, right? So on a test, if I ask you D5W and what happens to it once it's infused, you know that it's going to feed the cells with dextrose and that the water is a hypotonic that will go out and fortify this interstitial space in the cells and not stay in the intravascular space. Okay.
So you're saying, so nothing actually is going to stay in the space for that scenario?
Correct.
Okay.
Correct. Because it's going to leave and go to the cells in the interstitial space, and the dextrose is going into the cells for energy.
Cells for energy.
So would you
The only IV,
go ahead.
is dextrose the only IV solution that will not hypersonic that will go out?
No.
Okay.
That 3% saline solution that I had listed earlier, that
Yes.
sodium chloride is going to stay there and it's going to pull water in. But we can use other things than dextrose. Let's say that we were going to add potassium into fluids. So let's say we had 0.9% normal saline plus 20 MEQs of potassium. Potassium is your major intracellular or extracellular electrolyte? Intracellular. So potassium belongs in the cells, sodium belongs in the fluid, basically. Not that you don't have potassium in your blood, but it lives mostly in the cells. So like dextrose, if we infuse potassium, it's going to go into the cells as well, and we're left with this right here, which is what?
Which is isotonic.
So it's going to stay where we put it.
Right.
So that would be similar to D5%, 0.9% sodium chloride or saline. The only difference here is that in the top fluid, the dextrose is disappearing to leave us with 0.9% saline. And in the bottom scenario, the potassium is going into the cells to leave us with 0.9% saline.
Okay, thank you.
Does that make sense?
Yes.
It does, Miss Amick. I just got one question. How do you classify the D5W? Do you classify it as hypertonic, hypotonic, or is it a combination of both?
That's one that is so confusing. But if you have D5W, they're going to call it isotonic. If you look in your book, it's going to call it isotonic. And
not hypotonic?
Part of that,
It's not hypotonic?
Is that what your book classifies it as?
I'm just thinking because after the dextrose leaves, it'll just be pure water.
Right. After the dextrose leaves, then it is hypotonic. But your book I think this is the one that your
Yeah.
book calls it isotonic in the book because the 5% dextrose, when you combine it with the water, actually winds up being isotonic.
Yeah, the book does classify it.
So my thoughts
Yes.
was like they kind of cancel each other out because you got hyper and hypo, and so
Exactly. They cancel each other out. That's a really great way to put it. So it becomes isotonic. But remember, that's in that bag laying on the table. That's not what it's doing in the patient. So to me, it's very easy for you guys to get confused by looking at what it is on the table versus what it does in the body. So if for purposes of this class, I won't ask you what it is on the table. Because if it's not going into the patient, it's not changing anything anyway. So you need to know more about how these fluids act once we infuse them. So your D5W is going to be isotonic until infused. And then once infused, it's going to be hypotonic.
Yep.
All right. Now, any more questions? Okay. So all of the fluids that we're talking about right now are crystalloids. Because they come from crystals. When you go to the grocery store, what do you buy in crystals?
Sugar.
Sugar and salt.
And salt. So we use sugar and or salt to make crystalloids. The other fluid that we talk about in this, we're not going to talk about blood products because y'all can't give them at this level. And you have a whole lab and other stuff on blood products later on. So we concentrate on the crystalloids and what we call the colloids. Colloids are protein solutions. And the most common colloid is albumin. Proteins are very hypertonic. So if we infuse albumin, albumin is a water magnet. The fact that you have albumin in your blood is what holds water in your blood. Because colloids provide colloidal, osmotic pressure. Now, colloidal osmotic pressure means that your colloids are hypertonic, and so they pull water into the vascular space and hold it there to maintain the appropriate amount of water in your blood. So you have plasma proteins in your blood. Those plasma proteins are hypertonic, and they help water to stay in your blood, as opposed to leaving and going out into the other spaces. So just know that colloids are proteins that are hypertonic and that maintain the appropriate amount of fluid in our vessels through colloidal osmotic pressure.
So if you have low albumin, then you're going to have less water in your blood.
Yep. And where's that water going?
To the cells and the extracellular or the extra.
Yep.
Vascular.
So how's that patient going to look?
right.
Swollen.
They're going to have a lot of edema, and they may have ascites, and they're going to have water all over their body. So they're going to have edema. And so, yeah, when you look at their, where they're laying in the bed, if you move their extremities, it'll be indented from all the edema. Okay. So our colloids are a natural part of our blood that helps to hold water in there. Now, when we give them, we give albumin all the time. And we normally give it as a hypertonic fluid to help raise somebody's blood pressure if they're in a critical needs thing. We call these plasma volume expanders. Because if we give somebody albumin, it's going to stay in the blood, but it's going to also draw in some water to help raise up the blood pressure. So if we need to get somebody's blood pressure up, we need to fortify their vascular space, and regular fluids just aren't going to do it because there's not enough colloidal osmotic pressure to hold it there. Then we're going to use those plasma volume expanders. And for the purposes of this class, if you'll just know that albumin is a plasma volume expander.
Will you repeat that one more time for me? That last
albumin is the most common example, I guess, of a plasma volume expander or a hydrocolloid solution. And what it does is it increases the tonicity of the blood enough to pull enough water in to maintain the blood at the right percentage of water versus cells. So it maintains vascular volume through colloidal osmotic pressure. All right, last thing when we're dealing with these fluids. So we've said that we have these crystalloids that are made with sugars and salts. Well, sodium chloride is by far the most common crystalloid. And then you see a lot of dextrose. But remember that dextrose is making it hypertonic. When we're talking about isotonic, there's another fluid that you need to know about. And I'm going to tell you why it's different. So we have our sodium chloride. And then we have what they call lactated ringers or ringers lactate. It depends. Different people call it different things. So you'll see it written as either RL or LR, lactated ringers or ringers lactate. Both are isotonic. Because both equal 0.9%. Here's the difference. Sodium chloride has water plus sodium plus chloride, and that's it. So it's just salt water that's equivalent to the body's concentration. Lactated ringers, on the other hand, it's still 0.9%, but the particles in it are different. It has sodium, and chloride and potassium and magnesium. So it is made with electrolytes more than just your typical sodium chloride. So if somebody has an electrolyte deficiency, we would be better off to give them lactated ringers than we would just sodium chloride, because with sodium chloride, they're only going to get sodium and chloride. With lactated ringers, they're going to get different electrolytes. But what if they don't need those electrolytes? If they don't need them and we give the lactated ringers, it could cause their electrolytes to go up. And usually, y'all, with lactated ringers, we don't infuse it for a long time. Usually we'll give them a bag or two. But after that, we'll change them to something else, because this lactated part right here can cause lactic acidosis. Because that lactate will convert to lactic acid in the body. So if we give it to them over a long period of time, it's going to change their pH. And it's going to cause them to become acidotic. So we have to be careful how we use lactated ringers.
So you would never give any electrolytes with any other type of solution, right?
No, you can give them with other solutions.
Okay, but what if you gave it like, if you gave them their electrolytes with like a hypotonic solution, but like their hematocrit was off, how would you know you were doing the right thing?
If the hematocrit was off, if they needed more fluid, we couldn't give it with a hypotonic. We'd have to give it with an isotonic first.
Because you want to treat the hematocrit and then you deal with the electrolyte issue.
Correct. But we can give D5W plus potassium. We can give D5.5 plus potassium. We can give normal saline plus potassium. We can give magnesium. So if somebody needs electrolytes, we can mix those electrolytes in other fluids. But with lactated ringers, it comes pre-made, where it's got just a little bit of electrolytes in it that your other fluids don't, just to help replace or maintain electrolytes. So in other words, if you're going to give isotonic, you basically have two choices. You give sodium chloride or you give lactated ringers. Lactated ringers, you're really only going to give if you need to maintain or increase electrolytes. If their electrolytes are high, then you certainly can't use lactated ringers.
And how long, you said that one of the problems is acidosis. How long would you say, you're saying not to infuse for a long time? How long is a long time?
Well, normally we will give 1 bag or 2 bags. A lot of times when somebody comes back from surgery, they might have a bag of lactated ringers hanging because they're just wanting to maintain everything. But what they'll tell you is to finish the bag that's hanging, and then when that bag is empty, change it over to like normal saline.
Okay.
Yeah, you just can't use it for a prolonged period of time. So usually 2 bags is enough. So it depends on the rate as to how long it lasts. If you're running it at 125, it's going to last 8 hours. If you're running it at 100, it's going to last 10 hours. So it is not necessarily relative to the rate or the time, but more the volume that you give over such and such time. So 2 bags is usually a good strategy for replacement. Okay, don't get too much into this. The basic premise behind what I put up here was that you know that sodium chloride is isotonic because it has enough sodium and chloride added to it to equal 0.9%. Lactated ringers is isotonic because it has enough of many electrolytes combined to make it 0.9%. That's the simple difference. So lactated has electrolytes. Normal saline just has sodium and chloride. That's all you need to know. Okay. Any questions about fluids? All right. So what is the benefit to the patient with this fluid right here?
To
So
feed the cells.
It's isotonic. So
we're feeding the cells
Going to feed the cells, and
and
we're left with normal saline. So it's going to fortify where?
the vascular space.
The vascular space. If you can do that with these fluids, you're good. That's what you need to understand. So as you're practicing, don't look in your book and see what the fluid is, because the fluid, the book's talking about before it's infused. But y'all quiz each other to say, okay, what happens? Any dextrose or electrolyte additives are probably going into the cells. And then you have to consider what's left. So if it's 0.9% saline, it's going to stay in the vascular space. If it's less than 0.9%, it's going to the cells and interstitium. And if it's more than 0.9, it's going to pull fluid from the cells in the interstitial space into the intravascular space.
So would this be kind of like a question for the select all that applies? Like you would ask,
what's the benefit? All that apply.
Right. That's what, would that kind of be like a question on the test?
Absolutely.
Okay.
All right. So the electrolyte stuff, there's plenty of stuff in your PowerPoint for y'all to look at electrolytes. I'll also post some really helpful videos that will help you understand electrolytes. Electrolytes are the easy part of this lecture. The fluids and the acid base are the harder ones. So I want to talk specifically about acid base. So in your body, you have acid and you have base, and they buffer each other out. And what should our normal blood pH be?
7.35 to 7.45.
7.35 to 7.45. Okay. Now, our kidneys regulate and produce bicarb, which is HCO3. Our stomach, among other things, but our stomach mainly, produces acid, hydrochloric acid, other acids in our stomach. So these two work together to maintain our pH at 7.35 to 7.45. So if we have renal failure and the kidneys can't produce and regulate bicarb, the pH is going to go down and our patient's going to have too much acid, resulting in acidosis. Now, can we say, for the sake of argument, that our hydrochloric acid and other acids in our stomach and our bicarb are chemicals?
Yes.
Okay, those are body chemicals. All right. We're going to come back to what it means for them to be chemicals. But what I want you to remember is that if the kidneys regulate it, or the stomach regulates it, or it has to do with chemicals in the body, then it has to do with metabolism. So just kind of set that over on the back burner for just a minute. And let's talk about how to look at an ABG. So what does ABG stand for?
Arterial blood gas.
Arterial gas.
Arterial blood gas. Arterial. So what you want to remember is that arterial blood is different than venous blood. So when an ABG is drawn, we're drawing it from an artery, which means that the blood is oxygenated as opposed to deoxygenated in the venous system. So your values on whole blood from a radial, from a venous draw are going to vastly differ than an arterial draw. So with blood gases, we use arterial blood. All right. So in arterial blood, we have a pH 7.35 to 7.45, like we said. Then we have your CO2 component, and we have our bicarb component. All right. CO2 in the arterial blood is what?
35 to 45.
35 to 45. What is it in the serum?
23 to 30.
22, 26 is a good thing. So it falls within that range that you just said. But 22 to 26 is typically what we like to see. And then our bicarb in arterial blood is what? 22 to 28. All right. This is normal. So when you get your ABG back, you're going to start to evaluate it to try to tell what kind of acid-base imbalance your patient has.
Well, I'm sorry, what was the other number you said? It was 22 to 26. What is that?
That is serum carbon dioxide.
Oh, thank you.
Yeah. So most of the time we don't draw ABGs. Our respiratory therapist will draw the ABGs and go run it and bring us the value back. Now, most of the time, your ABG machine is in ICU. So if it's in ICU, you're going to get it pretty quick. Otherwise, they have to go run it and they'll bring it back to you. So here's how I want you to learn to evaluate your ABG. Number one, look at the pH. Less than 7.35 is acidosis. Greater than 7.45 is alkalosis. Now, hear the words coming out of my mouth right now. I am not teaching you to worry about compensation. You have acid-base balances, and then you have compensated acid-base imbalances. When I say compensated, what that means is that the body itself has tried to fix it. We are not talking about that. You'll learn about that in critical care. We're just looking at basic ABG evaluation. So you will never see on a test that I give you something that would be a compensated situation. If you want to learn what compensated is, that's fine. But if you're not already knowledgeable about ABGs, I wouldn't, because it gets real confusing. So as long as you can take an ABG and evaluate it the way that I'm fixing to show you, then you should be fine. Okay? Now you're going to get these same ABGs again next semester when you cover the oxygenation. Okay? All right. So when you look at your ABG, you can look at your pH first. If it's less than 7.35, you know your patient is acidotic. If it's greater than 7.45, you know that your patient is alkalotic. Okay. Number two, look at your CO2. CO2 represents acid. These carbon atoms right here make it an acid. So what that means is that if your CO2 is high, then you're looking at acidosis. If your CO2 is low, then you're looking at alkalosis. So you're going to kind of confirm after looking at the pH that the carbon dioxide, the CO2, is the same way as your pH. So if your pH is acidotic in uncompensated situations, your CO2 should be acidotic as well. Now,
is there ever a time when that they don't match?
In a compensated state, they might not match.
Okay.
But we're not going into all that.
Right.
We're just talking about basics. So basically speaking, you're going to look at your pH and then you're going to look at your CO2. All right, that's the easy part. So CO2, let's see, greater than 45 is acidosis, and less than 35 is alkalosis. Make sense?
Yes.
Because your CO2 is 35 to 45. Okay? So number one, look at your pH. Number two, look at your CO2. Once you decide whether you're dealing with alkalosis or acidosis, then you have to figure out metabolic versus respiratory. Now, just hang with me for just a minute, and then we'll go back and talk about why this is. Okay? So to determine metabolic versus respiratory acid-base imbalance, you're going to go to step number 3, which is to look at the bicarb. Bicarb is your alkaline. What's another word for alkaline?
Base.
Base. So bicarb is your base. So we've got our CO2 and our bicarb that together should balance each other out to give us a normal pH. But when they don't, then we have an imbalance. Okay, so here's the deal. Bicarb is only going to be abnormal in a metabolic situation. So if you've got abnormal bicarb, then you have a metabolic problem. So once you determine if you've got acidosis or alkalosis, then all you have to do is determine, okay, so is it metabolic or is it respiratory? Well, let's talk about metabolic first, because that's going to segue back over to what I was talking about with the kidney and the stomach. So we have our kidney that's responsible for bicarb. So with kidney failure, we're probably going to have a problem with acidosis, because if the kidney fails and we have decreased bicarb, then we have decreased base, which means we have too much acid. If you have somebody that has a kidney removed, or that was only born with one kidney, or any host of things, kidney disease, then you are more likely to have a metabolic acidosis because your body's not producing the base. Now, with your stomach, it produces our acids, and they go through our intestines and are absorbed into the blood, and they help to regulate our acid-base balance. So if our bicarb is high, then we know we have too much base and not enough acid. Or if our CO2 is low. Now, with our stomach, there are two situations, and you have to understand when the body would become acidic and when the body would become alkalotic based on the stomach. And I'm going to make this just as simple as possible. So if you have vomiting, or you have GI suction, where we're removing fluid from the stomach, we're removing
Acid.
the acid. So if we're missing the acid, then we know that that's going to cause alkalosis.
I forgot to move space.
Huh? All right. If we have diarrhea, however, if you think about the change from the small intestines to the large intestines, vomiting comes from the side of the small intestines. And it's acidic. So you lose acid. But in the large intestine, the acid's gone. It's been mostly absorbed. And so what you have in the large intestine is base. So with diarrhea, you lose your base. And become acidotic. So if the acid is coming out of your mouth, then you're going to wind up alkalotic. If you're losing fluids out of your lower intestines, then you're losing the base. You lose base from your butt, which is your base. That's what you're sitting on right now. So think about that as your base. You lose base from your base and you become acidotic. Now, in both of these scenarios, we're talking about the movement of chemicals. And again, anytime we're dealing with chemicals, we're dealing with a metabolic problem. So metabolic alkalosis comes from usually vomiting or GI suction. Can be from overuse of proton pump inhibitors that decrease acid production. And then metabolic acidosis can come from severe diarrhea or a problem with the renal system. But it's alterations in the chemicals. Okay, so before we go to respiratory acid-base balances, do you have any questions about the metabolic ones?
I just want to recap. You're saying that to be able to tell about the metabolic acidosis and alkalosis is we have to first look at the pH and see whether it's acid, if it's high or low, and then we would need to determine with the bicarbarates if it's metabolic, correct?
Correct.
All right.
Correct. If the bicarb is abnormal, you know it's metabolic.
Got it.
If the bicarb is normal, then you know it's not metabolic and it's respiratory. So let's talk about respiratory. Respiratory is easier to me than metabolic. So we have respiratory acid-base problems. All right. Remember that we said that carbon dioxide was an acid? You have to remember that when you're dealing with the respiratory system. So think about it. We breathe air in, it goes into our arteries. Our arteries carry that oxygen to the different cells in the body that need oxygen. And at the same time, our venous system is getting carbon dioxide and bringing it to the lungs for us to exhale. So we exhale CO2. All right, this is key. Respiratory acid-base balances are always caused by a change in rate and or depth of breathing. So respiratory acidosis and alkalosis depend on our respiratory rate and or depth. So in order to fix it, we just need to change the rate or depth. So, I'll give you an example. We have a 20-year-old female patient who is in the transition stage of labor. That means she's pushing. And she didn't take Lamaze, and she's flipping out, and she's breathing real fast and real shallow. Well, in that situation, she's blowing off all of her CO2, equivalent to somebody that was hyperventilating or having a panic attack. And so with hyperventilation, we have decreased CO2, which means we have alkalosis. And how do we fix it?
Give her some oxygen.
Increase their CO2 by like a paper bag or something, make them breathe it back in.
Okay, if we give them oxygen, that's not going to help them because they need CO2. If we give them oxygen, they'll use the oxygen, but then they're just still continuing with this altered breathing pattern that's going to blow off all that CO2.
We take them, they take deep breaths.
Okay, we can slow her breathing down and help her. That's why we have coaches in the labor and delivery. You know, you go to Lamaze, you have your coach. Your coach is responsible for helping you keep your breathing on task. Okay. Well, she didn't have a coach. She didn't have Lamaze. She didn't know how to breathe. So now we have to help her refocus. So we're going to refocus, and we could have her breathe into a paper bag or plastic bag or whatever we got. And what is the purpose of her breathing into a paper bag?
So
Going
she
to
can
increase her CO2.
Yeah, she's exhaling CO2, which then she's breathing right back in because the bag caught the CO2 so that she could breathe it back in and get her CO2 regulated. We can also use what they call a rebreather mask, which allows the patient to breathe back in their exhaled CO2. So with hyperventilation, they're getting rid of too much CO2, so we need to get them some more CO2. So in order to do that, we need to slow down their breathing, have them take some good deep breaths into a paper bag, and increase their CO2. And like I said, most of the time you see it in labor, you see it in somebody with a panic attack or somebody that's hyperventilating because of something. Okay? So respiratory alkalosis comes from hyperventilation and loss of CO2 through their breathing pattern. It's that simple. All right. Hypoventilation causes them to retain CO2. So they're retaining acid. So they will have respiratory acidosis. So give me an example of a patient that might have respiratory acidosis.
An overdose patient.
Okay, an overdose patient. Why?
Because they're not breathing adequately.
Okay, they're not breathing adequately. It's just that simple. So if you've got somebody that's overdosed or that comes back from surgery and they're very lethargic and they're not breathing well, they're going to retain CO2, which will result in respiratory acidosis. So with an OD, they, especially if they took a benzodiazepine or an opiate of some sort, it's going to decrease their respiratory center, so they're not going to breathe. And because they're not breathing, they're not exchanging oxygen and CO2, so they're retaining the CO2. So what we can do is with an OD, we can reverse whatever it is they OD'd on if possible. If they're a post-op surgery, we can reverse any anesthesia that they might have had. Or if they're able to wake up and cough and deep breathe, we'll just wake them up and say, hey, wake up. We need you to cough and deep breathe and, get that CO2 out of there. Now, your patients with emphysema and chronic bronchitis will also retain CO2 and become acidotic, because in your obstructive pulmonary diseases, it prevents the patient from exhaling the CO2, so it stays in their body and causes them acidosis. So we can put up here COPD, which we'll talk more about when we do oxygenation. But COPD or anything that decreases ventilation would then cause your patient to be respiratory acidosis because they're retaining that CO2. So for those patients, we're going to wake them up, try to get them breathing again, and reverse any substances that might be causing them not to breathe. And then with respiratory alkalosis, we're going to have them slow their breathing and breathe into a paper bag or a rebreather mask to increase their CO2 levels. Any questions about that? Okay. Last thing, I didn't talk about how to treat metabolic disorders. So with metabolic acidosis, we're going to infuse, sodium bicarbonate. Now, you see questions in your NCLEX books that ask you about fluids. You're never going to choose sodium bicarb as a fluid unless you know that you're trying to either treat or prevent metabolic acidosis. Bicarb is not a maintenance fluid. It's strictly used to help with acidosis. And then with your alkalosis, we need to stop the acid loss, because the gut will continue to produce acid. So if we can hold on to it, then we can get the acid built back up. So if they're vomiting, we need to stop the vomiting. Normally, patients aren't on post-op GI suction for long enough for them to get an acid-base balance. So that's usually not a problem. We take them off of it in a couple of days and they're fine. But if it winds up being prolonged gastric suctioning, then we may have to do something. We may have to stop it to keep them from having alkalosis.
So how do you stop the acid loss? How do you stop
You would have to stop the GI suction or stop their vomiting.
And so with stopping the vomiting,
right,
would it be with medication like antiemetics?
Yes. Yes.
Okay, yeah, that was my, like, how do you stop it? Meds. Okay.
Yep. Give them antiemetics. So when you get into the clinical areas, you're going to see that this gets much more complicated. But for what we teach you the foundation, and then each semester adds on to it a little bit. So that's the foundation of acid base. Now, I will tell you, we took care of a guy the other day who actually wound up dying. He came in from the ER, and they transferred him to the floor about maybe 5 o'clock in the morning. It was right before shift change. And he was fine at first, but then he started getting real whacked out and yelling and screaming at the staff and just being a butt. And we didn't realize what was going on, but they did an ABG and his pH came back at 6.8. Y'all, that's serious acidosis. And when they did his ABG, his CO2 came back at like 248, which normally when you see a CO2 that comes back that high, you're thinking somebody didn't draw arterial blood. They got venous blood, which would have a higher CO2 level. But his was accurate, and he couldn't keep his oxygen saturation up at all. He was down in the, I want to say the 60s. But he had terrible acid-base balance, and he wound up dying from it.
Yesterday, I had a patient whose labs came back, and their BGL was 1633, their pH was 6.92, and their bicarb was 2.
DKA?
Yeah.
Yeah. Yeah, and you know, when you have a metabolic panel that is that messed up, you're going to start seeing some serious organ shutdown and rhabdo and all kind of stuff that happens from the acidosis, especially acidosis that occurs with our type 1 diabetics. So yeah, it's amazing to see what some of these people come from. All right, so you guys email me if you have any questions, and I will post this evening some videos that will help you to understand the electrolytes. And again, I will have a tutoring session on Tuesday the 8th from 5 to 7.
Are you going to post this Zoom video?
Yes, ma'am. Absolutely. This one will take a little bit longer to come back from the Zoom people because it's so long. So I won't get it immediately, but I'll have it posted today. All right. Well, you guys have a great rest of your week. I will see some of you in pharmacology in a bit, and I will post how about this? How about I post the pharmacology Zoom link on the 155 page so that any of you that want to join can do that.
Thank you.
Sounds good.
Carl?
Yes, ma'am.
So you got that?
Yes, thank you very much.
Okay. All right. So y'all take care.
Thanks. You do the same.
All right, thank you.
All right.